So who here has absolutely no idea what peptide therapy is? Okay, sweet. I like it. Has anybody here personally ever experimented with peptides at all? Okay, I like it. So what I'm going to talk about today is an overview of what peptide therapy is, how we can incorporate this into our thinking on helping with pain and healing and regeneration. And just kind of at the end, we'll tie it all in together. There are a lot of different peptide products. I'm going to focus on 4 today because these are probably the 4 that I use the most in my patients with pain, where we're doing a PRP procedure or a stem cell procedure or anything else like that. And that's going to be BPC, Thymosin Beta-4, Pentosan Polysulfate Sodium, also known as PPS, and then the growth hormone Secretagogues. So peptides, right? We going real basic here. We have our amino acids, we have our peptides, and then we have our proteins. So our peptides are those linked amino acids before they start getting into that folded conformation shape. And so in reality, the term peptide is not specific for the peptides that you would get from a compounding pharmacy. We obviously have, I think it's something upwards of like 60,000 different peptides in our body that we have that are used for various functions. They are a signaling molecule within the body. And then here's our difference between our peptide, our steroid, and our amino acid derivatives. So these are going to be things like some of your neurotransmitters, adrenaline. Obviously, we all know about our steroid hormones. And then we have our peptide hormones over here. The way that peptides are going to work is they're generally going to be stored. This is looking at endogenous, not exogenous. So exogenous is going to be the things that we administer. Endogenous is going to be the peptides that we are all making naturally. The way these things work is they're basically going to hit a G protein receptor, which is then going to translate a signal through different signaling pathways that then is going to go to the nucleus and create the effect, okay? Not like a steroid hormone where cortisol is actually going into the cellular membrane and hitting on a nuclear receptor in the nucleus on the DNA. This is more of a signal transduction pathway. Can anybody guess what is the most recognized and widely used peptide in the world? Insulin. Yep. So again, insulin is, we make it ourselves from proinsulin, and we can also administer it exogenously, okay? And this is for anyone who did not know that insulin was a peptide. Some other common peptide hormones: ACTH, calcitonin, parathyroid hormone, vasopressin, oxytocin, gastrin, prolactin, and glucagon. And there's many more than this, but here's just a few. Just to kind of, and the reason I'm framing it up like this is because some people are afraid to get into peptides because it's like this new foreign land, foreign world, and it's kind of in this gray space with the FDA because all these peptides are GRAS, which means they're generally recognized as safe by the FDA, and so they don't have to be FDA approved in order to be made in a compounding pharmacy. And so I included this slide just to kind of show you that all the peptides that we're going to talk about today, one of the ones we talk about today isn't actually a peptide, but all the peptides that we use in clinical practice are already in us, okay? They're just in different concentrations. Obviously, we're going to be increasing the concentration when we go and do an injection. So anyone who's heard me lecture before knows that I always include this slide. I love peptides. I love regenerative medicine. The thing that I think is really, really important to keep in mind is this idea of helping to guide the body through a healing process as opposed to forcing a healing process, okay? And so I generally end up liking the peptides that have more pleiotropic effects, which means they're going to affect multiple different pathways of healing, as opposed to a single direct pathway. Because if you look on the extreme and you look at something like a COX-2 inhibitor, that is one of the most extreme versions of this is a single target, and because of that, we get a whole bunch of side effects because we are trying to, for lack of a better term, we're trying to play God way too much, right? We're trying to force a healing response or force a direction when we're nowhere near as smart as the human body. And so I like to help guide patients through a healing process as opposed to trying to force with a specific peptide or a specific growth factor or a specific protein. So let's hop into our peptides. So BPC 157, probably my most widely used peptide. It has a whole host of different effects, okay? It upregulates the growth hormone receptor on tendons. It stimulates angiogenesis, so it helps bring new blood flow into an area that might be devoid of blood flow. It's an anti-inflammatory, it's immunomodulatory, it increases nitric oxide production. Again, this is that pleiotropic effect. It's this whole bunch of other stuff that basically then the body can take what it needs and do what it wants with it, okay? I started cytoprotective because this is how I personally think of BPC working the most, okay? Cytoprotective basically just means it is going to protect a cell. And all the research, and we'll go through a few of those studies, but all the research that has been done, the one common thing about BPC is that it protects a cell when an injury happens, okay? And so, for example, if we have a transected nerve, right, in a rat model, well, they will actually cut the sciatic nerve, we see astronomically greater healing when BPC is administered directly after that injury. In clinical practice, I see that BPC works a lot better when we have some form of a stimulus, okay? Whether that's gua sha, whether that is cupping, whether that's Prolo, PRP, or stem cell therapy. It's something that is stressing and damaging a cell further than what it is right now. So that way, the BPC can help this cytoprotection side of the equation. The one really interesting thing about BPC is there are currently no published human trials on BPC. And most of the research that started coming out in the early 90s was from a group of Croatian researchers. Now, the story that I've been told that I've never been able to corroborate because I don't even know how I'd corroborate it unless I talk to the authors, is that this group of researchers discovered BPC many years before their first animal trial. They started using it in ulcerative colitis, so an IBD. Started using ulcerative colitis, had phenomenal results, went to publish it, was told, you can't publish this because you have no animal data showing that this is safe. They needed that first step of entrance into doing human research. So then they said, okay, we'll go back and we'll do a whole bunch of animal research. So they went on and did probably about 5 years of animal research in tendons, ligaments, nerves, cartilage, GI tract, whole bunch of stuff. And then they went and started a clinical trial on ulcerative colitis, which is still ongoing over in Croatia. So, so we currently don't have any actual human completed trials to show what we believe is happening with BPC. However, we do have, BPC is probably one of the most widely used in the ortho-regen space for peptides, and so it has a lot of at least anecdotal reports and data behind it. But when I'm talking with patients about this, I'm always upfront about that because I think it's important for them to have that consent before they make that decision. And obviously the question of, well, is this even safe comes up quite a bit. And this is generally what I talk about, is that the LD50, which is the dose that 50% of the population that takes this dose would die, so that's commonly used in research to look at toxicity, is greater than 125 grams in a human when you calculate it out, okay? Most of the time, our dosage is like 500 micrograms, upwards of 1 milligram a day. If we're doing intra-articular, we might do like 2 milligrams. So this is like an astronomical magnitude higher than what the LD50 would be. So we do have a little bit of peace of mind there. This here was the first animal study. And again, you'll always, unless I forgot it on the slide, but almost every slide I'll include what type of research it was, so that way you guys don't walk away thinking all this was human research, when in reality this was rat research. So here is the first study, 1993, on BPC. The other thing you'll start to learn about peptides is that a lot of this research has been around for a very long time. It just hasn't been in the US or Canada very long. Okay? A lot of it's over overseas, Russia, Croatia, some from Sweden. They found a stronger interest than we did. And my guess is because we were still kind of going through this really strong pharmaceutical boom at this time, and so peptides kind of fell off. One of the questions that I get a lot is there a difference between taking oral BPC, injectable BPC, or topical BPC, or even intranasal? Every single research study I've ever looked at, and again, these are all in rats, and so we could do a human trial and things could be completely different, but every single one shows that there is no difference between all routes of administration, okay? Clinically, there's one caveat to that, and that is when we actually do a guided injection under fluoroscopy or ultrasound, we do see better results when we actually deposit BPC and some of the other peptides directly into a tear or directly into the knee joint to bathe the cartilage, okay? Outside that, doing it, so some people will think, oh, if I have lateral epicondylitis or epicondylosis, if I do sub-Q injections over top of it, that BPC is going to get down into the tendon and it's going to help heal the tendon. If that were true, we could all start doing prolotherapy that way and we'd all have the same results, right? And we don't see that. What happens is you do it subcutaneously here, and the bloodstream will pick it up within a few seconds of that being sub-Q, and it won't dive down deep into the tendon. And so doing it sub-Q here, no difference than sub-Q in the belly or the glute, and then all the research studies show no difference between the different routes. However, clinically, I'll tell you this. Everybody has something that they respond to better. Okay? Some people do respond better to oral. Some people do respond better to injectable. The only way I have been able to kind of figure out how to guess which one might be right is what the patient's gut says. So I trust the patient's intuition. If a patient comes and says, you know what, I think I'm going to have a better response with oral versus injectable, then I say, all right, we're doing oral, or vice versa. If they don't have a preference, I generally just tell them to do oral because you don't have to worry about syringes and needles, and it's just a nice, easy oral capsule. BPC is one of very, very few peptides that are orally available, okay? You guys might see, once you go home and you're all excited about peptides and you go online and Google, you might see some different peptides that different companies have made that are in oral capsule form. The one that comes to mind that is a new recent one is a Thymosin Beta-4 frag, or a fragment of TB4 that's in an oral capsule. Those peptides are generally not stable in gastric juice, okay? The reason that BPC is stable in gastric juice is because BPC in us is naturally found in gastric juice, okay? So it's already stable there because that's where we produce it and that's where it resides. And originally, before these were all synthetically made with an amino acid sequencer, they actually used to isolate it from gastric juice, okay? That's how they made the first peptide. So in terms of this study here, again, this was a traumatic nerve injury, so they transected the sciatic nerve, and they saw an improvement in axonal regeneration. This here was our control with saline, and then we can see, obviously, increased neurofascicles here. Another study showing that the BPC promotes migration of the actual tendon. So when you sever a tendon, you're obviously going to have some outgrowth to help reattach it. And treating in a petri dish with fibroblasts from a rat, you could see increased migration of those tendon fibroblasts. Here's another one that I actually find really interesting, which is the BPC seems to increase the expression of the growth hormone receptor on tendons. Okay? We know that growth hormone and by consequence IGF-1 are important for healing. And so this is one of those mechanisms that I was telling you about where it's like, hey, this is not trying to force a pathway. This is more so like trying to help augment what the body is already trying to do, because we know that injured tissues already upregulate their growth hormone receptor, and BPC just helps augment that, does it a bit quicker and a little bit stronger. So now the growth hormone that you have floating through you can help to increase the healing. And then because of this, when we start stacking peptides, right, BPC and our growth hormone secretagogues, which we'll talk about in a bit, can be beneficial. So here's the good stuff and the reason y'all came. Here's how I dose it, okay? So we have our non-procedure dosing, and then we have our post-procedure dosing. Generally for non-procedure dosing, I'm doing 500 micrograms oral or 300 micrograms sub-Q. Those are the equivalent doses, okay? Obviously we get better absorption with sub-Q, so the dose needs to be less. So those are where we have the equivalent. We're going to continue that. We're going to do it minimum 4 weeks, and then we continue if we have improvement. If I start a patient on BPC and we're 4 weeks in and they have no improvement, it means they're not going to respond to it for whatever reason. My current suspicion is that it basically just means they already have enough BPC in their gastric juice that they actually don't need to have some form of supplementation of it. But if they are seeing improvements, we continue until they plateau. Post-procedure dosing, I'm going to do 500 micrograms oral for 4 weeks, and then 500 micrograms every other day for 4 weeks. We're basically doing 8 weeks post-procedure. And then we have the equivalent dosages there for sub-Q. Okay, and then save your questions for the end just so I can get through all of it, and then I'll answer anything you guys want. So our next peptide we're going to talk about is Thymosin Beta-4. First point of clarification is Thymosin Beta-4 is not the same as TB500. Okay? When you start looking into these peptides, you'll start seeing TB500 and you'll start thinking it's the same thing. Now, there's two errors that are happening. One is that certain places are calling TB4 TB500, and in that case, as long as they actually have TB4, if they're just improperly calling it TB500, that's fine. I mean, it's not fine because it'd be nice to have consistency, but it's not a different peptide. If you have actual TB500, that is a different peptide than TB4, okay? TB4 has 43 amino acids in it, okay? TB500 has 7 amino acids. It's a fragment. So basically what's happening right now in the peptide world is, yes, we are discovering how to synthesize new peptides and what they're useful for, but then there's research that's going on and saying, okay, of these 43 peptides, which of these amino acids actually bind to the receptor that's the anti-inflammatory portion of this? They find that, they isolate it out, they make a new peptide, and it's a fragment, okay? That's what TB500 is for. TB500 is more anti-inflammatory than TB4, and so they've basically isolated that TB500 out. But again, I like peptides that have a pleiotropic effects, so I prefer TB4 over TB500 because we're going to get a lot more different effects. It's not going to be as strong anti-inflammatory as TB500, but you're going to have more widespread effects that I think personally end up being better. So TB4 is naturally found in every single human cell in your body. It is upregulated when we have an injury, and so therefore it is found in higher concentration where we have wound healing, okay? Whether that's cutaneous wound or whether that's something like cartilage degeneration or something like that. Here's our pleiotropic effects that we talked about, right? Going to increase angiogenesis, increase cell migration. It is actually going to promote mesenchymal stem cell differentiation, and we'll talk about that in a bit because there's some caveats. It activates progenitor cells to help with native healing, and then also decreases cytokines. Its mechanism of action, it is the principal actin sequestering protein, which basically means it's going to bind to actin and it helps to move the cell. Okay, so it is actually responsible for helping to build the extracellular matrix cytoskeleton that we need. And so there's actually a lot of interesting research on TB4 with stem cells, because stem cells need a scaffold. They need biophysical forces in order to know what type of cell they need to become, where they might need to migrate to, and TB4 can help with that. Here again is just the two branches of TB4 being anti-inflammatory and then promotion of wound healing, and then just kind of everything we see with all of that. And you guys are all going to get this afterwards, so you don't have to worry about that. This is a slide talking just about how TB4 works. Basically what happens is you have this TB4 protein that is going to generate ATP using a hydrogen gradient that is then going to result in an opening of this P2X pore, which is then going to send out signals to result in cell migration. So that's how, one of the ways that we're seeing some actual migration of stem cells towards an area because of TB4. So again, if it's one of the first, first proteins that's upregulated on an injury, it would kind of make sense that it's sending out signals to the rest of the body to say, hey, send your stem cells to us so we can try to heal this. This was an interesting study. So what they did was they took human mesenchymal stem cells, they were bone marrow, and they took them, put them in a petri dish, and added TB4 to them to look at what would happen, okay? What they saw was that the TB4 inhibited the osteogenic pathway, the osteogenic differentiation of the stem cells, didn't change the chondrogenic pathway, and actually increased the adipogenic differentiation of MSCs. Now, there are some docs who will then say, oh, I won't do any TB4 if there's any form of bone lesion or anything like that, because of this study that says that TB4 is going to decrease the rate of osteogenic differentiation. However, this is in a petri dish. So what I take from it, because again, while some things are consistent where what happens in the petri dish is actually what happens in the body, a lot of the time it's what happens in the petri dish is slightly different than what happens in the body, right? And so the takeaway that I have from this is that I may not, under certain circumstances, want to mix my TB4 with my bone marrow and then inject it inside of a joint or inject it intraosseous to try and help heal a bone marrow lesion, okay? That's how I kind of think about it. So here are the indications that I would use Thymosin Beta-4. So any form of healing. I don't generally mix it directly with adipose or bone marrow derived treatments. And I'm unsure right now if I want to mix it with my adipose microfat and nanofat tissue transfers in the sense of not mixing it directly, but doing the normal 20-day course of TB4 after an adipose treatment. And again, my thought there is, well, if this research study actually does hold some weight in vivo, where if we do TB4 and it actually increases adipogenic differentiation of MSCs, then when we're basically taking adipocytes, pre-adipocytes, and we're moving them to a new location, maybe I don't want that. So I'm still playing around with that one and figuring it out. Here are my, how I dose it, okay? Non-procedure dosing. So if a patient comes to me and they have a nagging injury and they just want to try peptide therapy, we'll do 750 micrograms sub-Q daily. Generally, I'm doing a 20-day course, which is one vial from the compounding pharmacy I get it from. But you can do it upwards of 2 months. If you're going to use it intraoperative, meaning you're actually mixing it with anything, then we're going to be doing 250 micrograms per 5 cc's of injectate. And then post-procedure dosing, I used to just do the 750. However, I've kind of shifted a little bit, and I think I'm seeing better results. But I'm doing a higher dose, so I'm doubling the dose, and I'm only doing it for 7 days. So I'm doing 1.5 milligrams for 7 days. And again, my thought process is the following. After an injury, you have a huge upregulation in this gene that makes this protein, and then it slowly falls off like this. So I'd rather front load and boom, make this huge curve, and then stop and have levels slowly go down, as opposed to this slow up and then hold and then slow down. So I'm trying to mimic what might happen in the body. And again, compared to the body, I'm still stupid, so who knows? I could be doing it wrong. Okay, we're making good time. All right, let's go into the growth hormone secretagogues. These here, this was my first peptide love, okay, the growth hormone secretagogues. I first came across these in an underground forum even before med school happened, because I personally had a low back injury from a car accident that I could not heal. And so, you know, at 2 in the morning when you're searching the internet and you find the underground forums, right, you kind of go deep. So this was probably started circa 2012 for me. So the way that our growth hormone secretagogues work is that it creates a signal to the pituitary gland to secrete more of your own growth hormone, okay? There are 2 categories of these growth hormone secretagogues. There are the growth hormone releasing hormones. These are up here on our left, the GHRH. They are going to stimulate the GHRH receptor. Great name for it. The other class is the GHRPs, which are the growth hormone releasing peptides, okay? Those are going to stimulate the growth hormone secretagogue receptor, which is actually the same receptor that ghrelin stimulates, okay? So ghrelin's that signal that comes from your gut up to your brain to tell you you're hungry. When that happens, you're actually getting a pulse of growth hormone as well. The reason for that is because one of growth hormone's roles is to break down fat and move fat into the blood for you to have energy, right? And so if you're hungry and you need some energy, growth hormone tries to come in and save the day without you having to rely on cortisol and adrenaline, okay? Now, the really interesting thing is that we have this little pathway here. This SRIF is basically the fancy name for somatostatin, okay? Somatostatin stops the release of growth hormone, which is really, really important, okay? Because the way that growth hormone is naturally released in the body is in pulsatile spikes, okay? So you'll have very, very low growth hormone. In men, it's actually like undetectable in the urine. Women, it's a little bit higher. Women generally have less intense spikes and a little bit higher of a baseline. But we get this big spike, and then it drops hard. And what happens is during that spike, that growth hormone goes to the liver goes, oh my God, let's make IGF-1. It makes IGF-1, binds to IGF binding protein 3 and a few other binding proteins, and then circulates. So IGF-1 kind of does the grunt work of growth hormone, okay? So in a healthy human, the natural rhythm of growth hormone release is about every 3 hours, give or take maybe 30, 45 minutes. And that is mediated through somatostatin. So somatostatin basically binds to its receptor, puts the block on it, and then it comes off and it allows growth hormone to be released. Now, the other really important thing is that growth hormone is going to be made in the pituitary gland. And so the somatostatin blocking is really important because what it does is you put the brakes on, you allow the cells to make more growth hormone, so it kind of builds up, brake comes off, boom, pulse, okay? That's why that's important. However, when you're using the growth hormone secretagogue peptides, somatostatin's your worst enemy. Because if you come in here with a growth hormone releasing hormone, such as the Mod GRF, Thymosin or Sermorelin, which Sermorelin is actually an FDA-approved drug, and so you might know about that one. But if you just come in with this one, what will happen is it will stimulate the growth hormone releasing hormone receptor, which will then increase cyclic AMP and try to push out some growth hormone. If somatostatin is blocking growth hormone release at that time, somatostatin kind of wins, okay? You'll get a little bit of spike in growth hormone when you force it through the growth hormone releasing hormone receptor, but somatostatin is kind of just like, hey, no, I'm here, you're not getting out, okay? However, on this side, our growth hormone releasing peptides, they do something really cool. They bump somatostatin off of its receptor. And so, theoretical, if you could time it perfectly and you knew exactly when somatostatin was not on your pituitary receptors, you could just take a growth hormone releasing hormone, these ones up over here, and you would never need to use a GHRP. Good luck guessing the timing of that though, right? And so we pair these to the GHRP and the GHRHs because it basically forces that somatostatin off, so that way you actually get a pulsatile release in growth hormone that is much, much greater than using either of these alone, okay? Here is, let me actually show you this study first. This is basically what I'm talking about here, okay? So in our blue, so the orange is just a placebo. I don't remember what they used from, I think it was just saline, to be honest. Okay, so here's growth hormone release. This was a human study. So they gave intravenous bolus, right? Nothing happened with just saline, okay? They give the growth hormone, the GHRP, and look you got a little bump there, okay? You give a GHRP higher dose, okay? Here's our green, right? So this was 0.1 micrograms per kilo. This here was 1 microgram per kilo. And here's our GHRH, right? So we just get a little bit bump like that, right? So remember, our GHRH is on this side, GHRP on this side. So if you were to just take one of them, you'd want to take the GHRP, right? Because at the same dosage, you're going to get this versus this. But look what happens when you do them together. That's almost a threefold difference in growth hormone release. Again, because that GHRP is kicking off the somatostatin, which is allowing that GHRH to really help ramp up release of growth hormone. This is a study, again, in humans. Actually, it's the same study as this. Human study. This here, they were looking at basically what dosage do we need to use of the GHRP to get maximal effects. I wish they went a little higher than this. I would have loved to see 2 micrograms per kilo. But at 1 microgram per kilo, which for the average person is going to be anywhere between 70 to 100 micrograms, you're getting a much, much bigger increase in growth hormone. And so that will impact how we dose it. So here are 2 GHRHs, CJC 1295 with drug affinity complex. That is sermorelin. Drug affinity complex is basically this molecule that they attach to the GHRH, which allows it to stay in the blood longer, okay? After everything I just said with how we want this quick action pulsatile release, does it kind of seem dumb to make the GHRH just kind of stick around in the blood for a really long time, just kind of pushing against the growth hormone cells in the pituitary gland, okay? That's why sermorelin doesn't really work that well. However, the CJC 1295 without the drug affinity complex, which is also called Mod GRF, that one is in the blood for a really short amount of time. So it comes in, it boom, on that growth hormone receptor in the pituitary gland, which then signals that whole cascade to start. In terms of our GHRPs, okay, there's 4 main ones that most people in this space have used and experimented with, okay? The old ones are GHRP6 and GHRP2, and then we have hexarelin and ipamorelin, okay? Now, the older ones, they will have a stronger impact on cortisol and prolactin levels than the newer ones will, except for GHRP2, okay? That one was only mild to moderate. But the nice thing about some of these older ones like GHRP2, you got a really big release in growth hormone, but it came at a detriment to, you actually had an increase in cortisol, prolactin, and TSH as well, okay? And so the newer one, which is what I use, Ipamorelin, that one is what I call a cleaner peptide, okay? You don't get, man, if you really want to know what hunger pains feel like, go take some GHRP2. It is super, super intense. But you might actually want that, right? If you are using these peptides in patients who are underweight, you might actually want that because it's going to trigger hunger so strongly that they're likely going to be eating more, okay? So you can use that to your advantage. But Ipamorelin is just a whole lot cleaner, and so you don't get as strong of hunger pains, and you don't get large alterations in TSH, cortisol, and prolactin. Here are just, again, going through those 4 that I just talked about. 1st gen, 2nd gen, and then the 3rd gen is our Hexarelin and Ipamorelin. All right, the good stuff. How do I dose? So, remember I told you that every 3 hours or so, somatostatin comes off and allows that growth hormone release, right? So, what that tells me is that nature wants about 3 hours between each time that growth hormone is released in order to build up your reserve of growth hormone in the growth hormone cells to then secrete, okay? So because of that, we can actually dose GHRP and GHRH multiple times throughout the day as long as we are respecting the 3-hour time frame, okay? So you don't want to inject and then an hour later inject and an hour later inject and there's your 3 doses for the day. You'd want to space them out by about 3 hours. The more doses you do throughout a day, the higher, the more growth hormone pulses you're going to have that are stronger, the stronger effects you're going to get, okay? So our mild effect dosing, okay, which is basically just 100 micrograms, just because that makes it simple, 100 micrograms of both of those once a day. I generally tell patients is good for maintenance dosing and if you do it long term, some anti-aging benefits, okay? The moderate effects, so when we do our BID dosing, that's where we start to see some improved healing times around post-procedure and that kind of stuff. Going up into our strong, max, and then our Super Saiyan doses, those are generally more reserved for bodybuilding world, okay? Where someone's not using growth hormone, but they're wanting to try and maximize their, the effects of growth hormone. That's where these doses will start to come into play, okay? Because this one here, this is probably through a compounding pharmacy gonna cost you about $2 grand a month. So super expensive, okay? When you start getting into, right, so my preferred time to take it is at night, right before bed, okay? You always need to take it on an empty stomach, okay? If you have fat or carbohydrates, that blunts the effects of the growth hormone secretagogues. And not a lot of people know that. You only know that if you were part of underground forums in the early 2000s. But there's research showing that you get a blunting effect of these peptides when you have carbohydrates or fats floating through your system. So my instructions to patients are 2 hours before, no food, and then 30 minutes after, no food, okay? So preferred time is right before bed. 10% of patients will have some insomnia and it's a little bit harder to sleep. And so if that's the case, then I just move their preferred time to right in the morning when they wake up. If we're doing BID dosing, I'll do morning and night. Again, it's super easy. It's at least easier to do it morning and night than just to try and plan it out through the day. And then once we get into 3 times a day dosing, I'll generally recommend that based on what the goals of the patient are, to either do their dose right before a workout or right after a workout, okay? I'll do it right before a workout if they want to lose weight, because you're going to take the growth hormone secretagogues, you're going to have increased lipolysis, so now you have more free fatty acids floating through the blood, and then you're going to go work out. And you're going to burn off more of those than you would if you didn't take the growth hormone secretagogue. And then if they want to focus more on muscle building and mass, then I'll dose it after, because that anabolic window after, and then within 30 minutes after that, they then get to have their post-workout meal. And we are compounding the nutrient status on the growth hormone and IGF-1 floating through the blood, okay? All right, PPS, or Pentosan Polysulfate Sodium. So this is not a peptide. I include it in everything like this because you can really only find it in its injectable form sold by the compounding pharmacies that make the peptide. So it gets included, it's like grandfathered in. Okay, it's a semi-synthetic polysulfated xylan, which is basically a modified glycosaminoglycan. Okay, it is actually an FDA-approved medication for interstitial cystitis and bladder pain syndromes. Okay, the older research showed it worked really well. New research shows it doesn't work that great for IC, and I haven't dug into that research because I don't treat IC. So I don't know if that's just they're doing better research studies or if something else is different. But in this form, for IC and bladder pain syndromes, they're taking it orally, okay? However, for knee-OA, it has some really interesting results, okay? It can affect pathways involved in inflammation, like NF-kappa B and the IL-1 beta NOS pathway. And there's also a research study that came out just last year that showed it can actually help with the pain that is associated with advanced bone lesions that you would typically see with osteoarthritis, okay? Here's the first study on PPS for knee osteoarthritis in 1992. Yeah, 1992. Okay, so they did 4 to 6 intra-articular injections. And in this study, they saw improvements, okay? So that was the first study, the intra-articular. By the way, PPS is used a lot in horse racing. Generally, they'll use it prophylactically before competition season because of how well it helps to maintain collagen, extracellular matrix, and cartilage. So here's another study that looked at patients with Kellgren-Lorne grade 1 to 3. So this is our mild to moderate osteoarthritis. They did 2 milligrams per kilogram sub-Q weekly, once a week for 6 weeks, okay? What we see here, now this was an open clinical trial, which means it's not double-blinded, so you have to take that into consideration because there's no placebo to know if this was a saline injection, would they have had the exact same outcomes? But what we do see is that we see a reduction in VAS, or visual analog score, that continues out to a year past this 6-week trial. Okay, so they're seeing actually long-term results. And then over here, this is degree of flexion, because with osteoarthritis, one of the bigger complaints other than pain is a loss in range of motion. Okay, so these patients started to regain their range of motion that, again, also was statistically significant out to a whole year, okay? And then this here was looking at their, the WOMAC pain scores between them. So again, we see this was not statistically significant, and I included it because of that, but it showed a trend towards lower WOMAC scores. For anyone who doesn't know, WOMAC scores are basically a scoring system for osteoarthritis. So going back, this was 2010. Oops, wrong way. Going back 5 years, there actually was a randomized double-blind placebo-controlled trial where they did similar injections. Okay, I believe this one was bi-week. They did it twice-a-week injections for 6 weeks as well, or sorry, for 4 weeks. So they did the 8 doses over a 4-week period. And what we're seeing here is that our, I can't read this one. Oh, our stiffness, okay? So here is our placebo where they use saline. Here is our PPS, okay? So in terms of morning stiffness, how long that's lasting, we see a great reduction that was statistically significant, that then eventually at 24 weeks it wasn't statistically significant anymore, but during this time period it was. And then over here is our VAS score, so again our visual analog score for pain, and again in our PPS group we're seeing a reduction in pain scores that were statistically significant compared to saline. So we know, based off this and this study putting these together, that we do have some weight behind PPS for osteoarthritis. This study here was the new one that I was talking about that came out in September, that basically showed that the PPS inhibited our basal secretion of TNF-alpha, as well as pro-NGF and NGF secretion, excuse me, and also reduced what's called the TNA-alpha induced levels of the collagenase MMP13. So MMP13 is a really terrible matrix metalloproteinase that breaks down cartilage. TNF-alpha, TNF-alpha induces MMP13 and therefore contributes to joint degeneration. So in research studies, what they'll commonly do is they'll take the cartilage, the chondrocytes, they will add TNF-alpha to it, and they'll add whatever they're testing. So in this case, they added PPS and the TNF-alpha to it, and when you compare that to just adding TNF-alpha, the rate of MMP13 production was lower. So we could make a semi-strong case that, okay, if we put PPS inside of a joint, then we might see a reduction in this matrix metalloproteinase 13, which could help shift the catabolic to anabolic environment, which could then help with regeneration of the cartilage. And this is basically how I classify and think of PPS. It's helping stimulate collagen synthesis, and it's helping stop cartilage breakdown. Okay. So I don't really use PPS for much anything else outside of knee-OA. I've not had a patient with like subtalar or talocrural osteoarthritis to test this on. I've only had knee-OA so far. Here's how I dose it, okay? 2 milligrams per kilogram, IM injection. You can do sub-Q because the studies show that, but I just prefer IM. Twice a week for about 6 to 8 weeks. The reason there's that 6 to 8 weeks is because the vial size that it comes in, right? So if a patient has, and the patient I'm thinking of, he weighed about 80 kilos, so we did 160 milligrams, and he ended up getting 7 weeks out of the vial that he purchased, okay? So in a smaller patient, I'm totally okay going out 8, 9 weeks because there's nothing in the research showing us that going for longer is detrimental. If anything, it might actually be a little bit better. And then if we're going to do intraoperative, so I'm actually going to inject PPS into the knee joint, I'm going to do about 250 to 500 milligrams inside the knee joint. And that just depends on, I'll do higher for grade 4 and lower for kind of grade 2 to grade 3. And then post-procedure dosing on this one, I'm still kind of playing around with this. So right now, I'm still just doing the 2 milligrams per kilo. But I'm experimenting with different ones, and next time I give this talk, it might be different. And then here's who I'm using it on, okay? Knee-OA, where we have subchondral bone marrow edema, and then and definitely our patients with grade 4 severe osteoarthritis. Okay, sweet. How to tie this all together, okay? This is how I personally think about using peptides in conjunction to make something that is not just, okay, you're having a procedure, take this one peptide, okay? The way I'm thinking about it, and maybe Danny will invite me back one day to do a longer lecture that includes this first part, but before a procedure, I want to activate senescent cells, so we want senolytics, and I want to induce autophagy and mitophagy, basically to make the environment of the human healthier, so that way when we come in with a therapy, they're going to respond better, or they're likely to respond better. Then afterwards, I use therapies that are going to promote anabolism, growth, and differentiation, okay? So things in our autophagy and senolytics that I'm exploring, using, experimenting with. Fasting, big fan of fasting. Rapamycin and rapalogs, quercetin and dasatinib, our NAD, and then some of our peptides, thymosin alpha, MOTC, 5-amino, 1NQ. and our FOXO4 peptide, okay? These kind of all stimulate the senescent cells to kind of not be senescent anymore. And then in terms of our growth and differentiation, I think I'm a huge fan of collagen. I think it works super, super well for patients. Most patients, especially women, need to up their protein intake after procedures because they're getting nowhere near what we want to maximize healing. So my bare minimum is 1 gram per kilo. So if a 60-kilo woman, I'm doing a procedure on her, I at least want her getting 60 grams. More ideally would actually be 2 grams per kilo, okay? So that's gonna be about 120 grams for her. We all know that Zach definitely gets more than 2 grams per kilo. Our NAD, again, is still beneficial at this time point, and then our peptides. The 3 that we talked about here today, I didn't include PPS because I'm still figuring out that one post-procedure. But then 2 other ones which I knew I wouldn't have time to get into today, which is GHK copper and the pegylated form of MGF. Sweet, here are my sources. And we got 7 minutes. Obviously, I'll stick around after if anyone has questions. But anybody have any questions right now? Zach?
PPS dosing?
What's that? Which one, sorry?
PPS. That one. The study was sub-Q. Do you do IM?
Yeah, I think there's been 2 or 3 studies that are IM, 2 or 3 studies that are sub-Q.
And have you clinically seen better results with IA? Comparative?
Yes. Yeah, but the way I'm kind of approaching it right now is if a patient is going to or is considering getting a stem cell procedure and also considering a knee replacement, and they're not sure if they want to pay for a stem cell procedure, I'll generally say, do this. It's a few $100. Do this for 6 weeks and let's see what happens, right? Because they might do it and that might get them to a place where they're like, okay, I don't need to do a knee replacement. It's now a little bit more tolerable, and then I can figure out what else is going to happen. Yeah.
How do you tease out when to not add BPC to Prolo, or do you often?
So I generally don't add anything to Prolo, and it's just that my thought process is it's a low-level therapy that generally I'm really only recommending Prolo to patients when there's a financial barrier, just because PRP is indicated for everything Prolo is, and it just does it so much better. And so for the price point, when I compare what my cost of PRP is to my cost of Prolo to the patient,